go to the next case, or actually to the so-called how-to session, and I now want to show you what we should be looking for if we assess patients with coronary artery disease. Okay, here again is the patient that I just showed you previously with an infarct in the anterior region. Okay, let me go to the following patient. Wait, I have to switch again to the other presentation. I'm sorry. Okay, this is another patient. No, don't mind the history of the patient. It's not relevant for what I'm going to show you. First of all, when you look at patients who have coronary artery disease or where you suspect coronary artery disease, use as many views as possible. And you can even use the parasternal long axis view, because in this view you do see a number of segments which are very important. Right away, if you see this loop, the diagnosis should be clear. The patient has a problem right down here. The wall is thin, it's not moving, right? And this region is the posterolateral wall. So one view alone will give you the story, but it will not give you the entire story. The next thing you need to do is you need to do short axis views. Personally, I don't really like to assess wall motion abnormalities only on the basis of short axis views, because you can be quite off in many instances. In this case, I would say it fits quite nicely to what you see in the parasternal long axis view. We have thin and scarred posterolateral wall. However, be cautious, we're very close to the mitral valve here, right? So usually function down here is less than this in the further apical parts. But if you just move down a bit, this kind of spreads further down as well. So you can kind of confirm the diagnosis if you use several of these short axis views. And now let's turn to the apical views. This is an apical. I'll just show you this one is better. The most important thing for assessing wall motion abnormality is to have best image quality you can get. This is where your skill in imaging really counts. So you see we played around a bit. This is what we started out with. And you see this is suboptimal, right? Again, this is not a good view. We have foreshortening. The ventricle here is much too short. Right? See, it's somewhere in the range of 78. And then if you move the transducer a bit and you play around with it, all of a sudden you have a much better appreciation for the ventricle, and you can really assess the wall motion here. Now look at how long the ventricle is now. Yeah, it's much larger than you had before. So whatever, you need good image quality. And if you now look at the wall motion, what you have to do is you look at several things. The first thing you look at is how is the myocardium thickening. Thickening is an important factor, but don't believe the textbooks. It's not the only thing to be looking for. Look at other things as well, such as hinge points. I will show you what I mean by a hinge point in this view here. This is the anterior wall, right? And here all of a sudden we see an abrupt change in the way the myocardium moves. This moves normally, hyperdynamic, while this region here is kind of hypo or akinetic. Okay? Good. So what you have here is a hinge point. This would be the hinge point right here. The next thing you have to look at is what is the thickness and the echo density of the myocardium. Right here, it's rather thin. You see that there is a myocardium which is not even half as thick as the septum. And this means that there is a scar. What does that tell you? It tells you the infarct is old. It's not a fresh infarct. There is fibrosis. And it will tell you that there is no sense in revascularizing this region. The next thing that jumps to your view should be, like I said, the shape of the left ventricle. If you have an infarct, usually you have some kind of distortion of the ventricle as well. sometimes you can even make the diagnosis simply by looking at a still frame. And this might not be the classic example where you can do this, but very frequently you will see that there is kind of a distortion here or in the inferior wall or in the apical wall, and this also contributes to you making the diagnosis of wall motion abnormality. And then another thing to look at is not only the standard views, in this case the 4-chamber view and the 2-chamber view and the apical long axis view, which as a matter of fact is the same view that we have here in the peristernal view. We have the same wall motions, the same regions as we do here in the apical long axis view. Okay. I see that some of you are already speculating on which vessel is affected. I'll come to that later. Philip has an opinion here which I will come to later, but the point I first would like to make is that in reality this view here shows you the same segments as this view here, with the only difference that in this patient image quality is better than in the peristernal long axis view. So use all of these views, but also use a view where you kind of tilt the transducer or rotate the transducer clockwise. By doing so, you will get this part of the wall into your field of view, which is the lateral wall. And if we go through the different segments, you will see that we have wall motion abnormality here, posterolateral. We have a wall motion here in the inferior wall, which is, basal and mid. But we also have a wall motion abnormality lateral, right? This is often missed. So in conclusion, this is a fairly large infarct where we probably do have some viability because the myocardial thickness is still present here in the lateral region, while this here seems scarred. Before I turn to the angiogram of this patient, just let me show you what else we do in these patients. We look at the valves. Why is this so important? Because it gives you information if we have some form of mitral regurgitation, for example, which is caused by the infarct. Remember, infarcts can cause secondary mitral regurgitation by influencing the geometry of the mitral valve. For example, in inferior infarcts, you will frequently see a so-called restricted posterior leaflet, which causes MR. This is not the case here. There's only mild MR here. And the other thing you look at is ejection fraction. And there's several ways of doing it. Here I used a technique which is called the auto-AF, which means that you kind of have the system do it for you. It sometimes works quite well. Sometimes you do have a bit of discrepancy between what you think and what you have. But in any case, it's 53%. But be cautious when you look at ejection fraction, because especially in the setting of infarcts, this can be very tricky. First of all, very frequently, you will not have the posterolateral wall if you do the Simpson, which means that this region where the infarct is largest is not, being considered when you can calculate the ejection fraction. And here we have a value of 53, which grossly overestimates ejection fraction. We only used a 2-chamber view and a 4-chamber view here. So ejection fraction does not work in this setting. By the way, if you're interested to read more on this topic, we just had a newsletter out which is called Challenging the Holy Grail, which I would really recommend you to read because it gives you my point of view on the value of ejection fraction, and it tells you how useless it often is and how you really have to know the background before you use it into your clinical decision. Okay, but going back to ejection fraction, in this case, don't forget that we have certain segments which are hyperdynamic, while others are akinetic or hypokinetic. So it kind of compensates out to a certain degree. Okay, now let me go to the speckle tracking of this patient. Remember, I showed you that this is something which really gives you additional information, and I think it does. This is the speckle tracking reading of this patient. Look at the image here. Again, it fits very nicely to what we see. We have the posterolateral wall, the lateral wall here affected. That's where the infarct is. But we have the territory which surrounds that, which is also affected to some certain degree, the inferior wall and so forth and so on. The best function is usually in the apical segments, unless you have an infarct there, obviously, because the apex tries to kind of compensate for this part of the myocardium which starts to fail. Many of you have already commented on what you think the culprit lesion is or culprit vessel is, and I will now go back to the coronary angiogram and show you this. Okay, this is again the speckle tracking I just showed you, and now this is the coronary angiogram of this patient. Again, the catheter is stuck here in the left main. This is the left main, which is a fairly long main stem, and then the angiogram kind of the vessel splits into the LAD, which looks fairly okay. Okay, there's no stenosis I see here. It's just some wall motion, some wall abnormalities. But if you look at the circumflex artery, it's occluded. Right here, that's where it stops. It's total occlusion of the circumflex artery. And as Philip and many others of you correctly mentioned, this fits very nicely to the region of wall motion abnormalities that I showed you in the echo. It's posterolateral, lateral, and partially inferior. Again, you see here, there's just an abrupt stop in flow of contrast. Okay, so just to summarize, what should you be looking for in patients with coronary artery disease? Obviously, wall motion abnormalities, where they are. Look at if the myocardium is thick or thin, or if there's a scar. You look at, obviously, which vessel it could be. You can try to see if you are able to determine if it's an LAD or RCA or a circumflex, as we did in this case. And also take a look at what the risks are in the individual patient that there will be remodeling. Remember, remodeling means the increase in the size of the ventricle and further deterioration of left ventricular function. And the factors you have to look at is what is the extension of the scar? Is it large? You have to look at what is the size of the left ventricle and what is its function, and if the patient has mitral regurgitation, because this is an additional factor which predisposes to remodeling. What are some helpful tips again? Look at the angiogram in patients if you have the option and the chance to do so, because you will learn so much. You have to compare what you see on the angiogram with that what you see on the echo. You will then have a much better appreciation for how lesions manifest themselves with respect to wall motion abnormalities. And consider that the case I showed you here are fairly simple cases because there's only one vessel involved. If you have more vessels involved, things can get much more difficult. The next thing is you have to follow patients and compare. What do I mean by that? It means that if you have this patient who has an acute infarct, take a look at him maybe 2 or 3 days later, a week later, a month later, a year later, and then finally you will get to much better appreciation of what is still salvageable and how did the ventricle change. You will see which patients develop remodeling, which don't. Use as many views as possible, especially atypical views. Use strain and be uncertain. To be honest, there's so many situations where I am not sure if there's really a wall motion abnormality or not. It's probably the most difficult thing in echocardiography. And what I basically do is I just write in the report, it could be, maybe, I'm not certain, it looks as if. These terms does not mean that you are a fool. You do not know what the real truth is. It just tells you that there is a suspicion there, and it would at least give the people who refer to you the option of looking more into detail and maybe performing another stress test. Finally, there is just one other question which came in. How do we know the normal heart anatomy on speckle images? The normal anatomy is kind of defined, let me go back to this here, it's defined by the bullseye. You have to look at it from the following way. You see the heart here, and you kind of spread the heart open. You open it up and fold it up, and you look at the ventricle from the top, and the center regions would then be the apex. This would be the mid segments, and those are the basal segments. You have labeling here on this bullseye view anyway, which tells you what is where. This is inferior, posterolateral, lateral, and thereby you can describe all the different segments that there are. Remember, we have a 16-segment model. With speckle tracking, we use a 17-segment model. But anyway, it's just very similar. All you have to do is you just imagine you're looking at the heart from the top, and you're folding the heart kind of open. This is how we correlate basically the anatomy.